Civic has been involved in with several other states or entities, civic-like entities in other states. And the purpose is really to kind of walk you through what we've been doing and to share some of the findings, both how Colorado compares to a number of other states nationally in terms of cost and utilization and prices, as well as to give you a sense of how utilization and pricing vary across the state of Colorado. And since we're right on time and there's a lot to cover, and it looks like we've got 43 participants on the line already, I'll go ahead and get started. My name is Jonathan Matthew. I am the Vice President for Research and Compliance and Chief Economist here at Civic, the Center for Improving Value in Healthcare. My background is in economics. I've been with Civic since January of 2012, just as we started collecting data for the Colorado APCD. We've been a part of this project now since November of 2013, and more about that in just a second. So the Total Cost of Care project, it goes by a number of different names. Getting to Affordability is the name of the broader effort at Network for Regional Healthcare Improvement, who's been leading this work since 2013. But what this is a multi-state project, as I mentioned, led by the Network for Regional Healthcare Improvement. The project has been funded. We're now in our third round of funding from the Robert Wood Johnson Foundation. We're very grateful for their support. As I mentioned, the initiative got started in November of 2013. We're in our third round of funding, and we've been generating, among other things, practice level reports that we've been sharing with primary care practices here in the state of Colorado. The results that I'm going to talk about a little bit today are based on Colorado data for commercially insured individuals in 2015. This data comes into the Colorado APCD under Colorado APCD statute and rule. Reflected in the results that I'm about to show you are information or claims data from 14 commercial health payers. As part of this initiative, as I mentioned, we've been sending reports directly to primary care practices, both adult and pediatric. And in the most recent release of reports in October of 2013, or October of last year, 2017, we sent practice level reports, very detailed information to 102 adult primary care practices and 24 pediatric groups. A little bit on the Network for Regional Healthcare Improvement, ENRI. Again, that's the national organization based out of Portland, Maine, that's been leading this work since 2013. The original 5 participants were Civic here in Colorado, Maine Health Management Coalition, Midwest Health Initiative out of St. Louis, Minnesota Community Measurement, and Oregon Q-Corp, or Healthcare Quality Corporation. During the first 18 months of the project, those 5 entities worked together with ENRI to implement the Health Partners Measure Set and to get practice level reports out summarizing these results to adult and pediatric primary care practices. Since the original pilot, a number of other regions have joined. All of these organizations are what are called Regional Health Improvement Collaboratives, or RICs, and those are just the name given to members of the Network for Regional Healthcare Improvement, or ENRI, and I'm not going to read them off, but it gives you a sense that we've significantly expanded the reach beyond the 5 stars, the 5 initial participants, to those blue dots that you see there on the map. And so this is catching on in lots of other places in a number of different ways. So why does this matter? Anna English, our CEO, likes to ask, so what's the so what? It's important to understand variation in healthcare cost, which is made up of 2 components: the prices of the services consumed and the volume of the services consumed. If you think back to economics, total revenue is price times quantity. If you sum that up across all goods and services, you get total cost. Well, we're talking about total cost of care delivered to commercially insured patients. And you need to understand, and this will become clear throughout the presentation, you need to understand all 3 components to really know what's driving differences across regions or across states. But a couple of fun facts. This is information that'll be familiar to anybody who follows healthcare. Between 2006 and 16, premiums increased by 77% for a family with employer-sponsored insurance. Median household income increased by only 19%. There's a lot of information out there that suggests that what modest gains workers realized over the last 10 to 15 years in this economy, the vast majority of those wage gains went to paying for more expensive health care. By 2030, Medicare beneficiaries are estimated to pay up to half of their income for out-of-pocket health care costs. And, you know, opportunity cost is something that matters here. The more you have to spend on one category of goods and services, healthcare, the less you have to spend on food and housing and clothing and other things. Again, there's a number of studies out there based on the Choosing Wisely campaign that's been around for a few years now. There's estimates that suggest as much as 30% of healthcare services are low value or don't provide value to the patient, and in some cases might do harm. So there's a lot of opportunity to bring down the cost of healthcare, but as this research points out, we really need to understand what's driving costs, what's driving cost differences if we're going to design policies, effective policies intended to address that. This study is different in a couple of important ways. One, it involves multiple states. Elizabeth Mitchell, the president and CEO of ENRI, approached Robert Wood Johnson many years ago about funding this kind of work in Maine. And finally, after many, many discussions, RWJF said, bring me multiple states and we can talk about a specific project. And that's how the original 5-state project got started. But most studies were either theoretical or too broad to generate information that people could act upon, or focused in on very small parts of the overall problem and didn't really contribute to broader policy solutions. So as you'll see, I think in the course of this presentation, the results that we've generated are state-specific, can be meaningfully compared across multiple states, and actually provide some information on where to look next in terms of designing actionable policy to address healthcare costs. We've always had some information, anecdotal information, that there's a lot of variation around the region, that costs are higher or utilization are higher in different parts of the state. This really puts a finer quantitative point on some of that anecdotal evidence and helps us to take a more objective view with respect to variation around different parts of the state. And then finally, the multi-state analysis gives us a sense of how we compare to others and what's driving those results. So, you know, taken together, there's a lot of good stuff here. So what did we find? In Colorado, compared to 4 other states, the total cost of care for commercially insured individuals on a per member per month risk-adjusted basis is 17% higher than the average across the 5 states. So Oregon, Utah, Colorado, Minnesota, and Maryland went through the process to generate these results. On the front end, there is a lot of validation of the raw claims data to determine which payers and plans get included in the analysis. And on the front end, we want to understand if we want to see for a particular health plan that we see stable numbers of members, stable numbers of claims month to month, stable numbers of dollars. And if you divide dollars by months, you get per member per month spending. We want to see relatively smooth patterns in per member per month spending, and plans that showed stability in those areas, plans that had stability in those areas over multiple years. Those types of plans were included in the analysis. Plans that had data that looked a little funny, we generally removed those or worked with the payers to get the data to a point where we felt that it was an accurate representation of utilization and spending for commercially insured populations for the period of this study, 2015. Digging in a little bit deeper, okay, so Colorado is 17% higher than the average across the 5 states. Maryland is 16% lower. Oregon turned out to be no different from that average. Utah was a bit below, and Minnesota a bit above. So digging in a little bit in this slide, what's driving those results? If you look on the left-hand side and look at the results for Colorado, the green portion of the bar represents the contribution of price to the result in the map. The blue bar represents the contribution of utilization or resource use to the result summarized on the map. And Colorado's 17% above average was driven by 6% higher prices and 11% higher utilization, again, relative to the average across all 5 states participating in the study. Maryland shows up at 16% below average, driven by 3% lower resource utilization and 13% lower prices. If you read the report that summarizes these results and provides some detail around methodology, you'll learn that Maryland has had a budgeting system for hospital budgets in place for over 30 years. And I think it's safe to say that that policy has had an impact on the cost, especially of inpatient and outpatient services in the state of Maryland. For 4 of the states, the impact of resource use and price work in the same direction. So both positive in Minnesota, both negative in Utah. Oregon is interesting in that price and resource use or utilization work in opposite directions. So Oregon saw resource use that was 8% below average, and what that means is that Oregon providers are relatively efficient in providing care to their patients. They use fewer resources, 8% fewer resources, than the average observed across the 5 states. However, their prices that paid for those services in Oregon are about 9% above the average observed across the 5 states. A little bit of rounding error there, but in the final analysis, the 9% higher prices essentially cancels out the 8% lower utilization, and Oregon appears to be no different from average in terms of risk-adjusted total spending per patient per month. With apologies to Uwe Reinhardt, who many years ago wrote the article, "It's the Price is Stupid," when trying to explain why healthcare costs so much in the United States, what this analysis clearly demonstrates is that it's both. The excess or value below the average in terms of total spending is driven by both resource use and or utilization and prices. Sometimes those things work in the same direction, sometimes they work in opposite directions. The implication for Oregon is interesting. With already 8% below average resource utilization in Oregon, policies intended to make providers more efficient or reduce their use of services and treating their patients further are unlikely to be successful. But prices, on the other hand, being 9% above the average across the 5 states, policies intended to help reduce prices in Oregon could be effective in bringing down costs per patient per month even further. We wondered a little bit about Colorado's outlier status, having 17% higher costs relative to the average across the 5 states participating in the study. And there aren't a lot of studies like this out there, but in December of last year, the Healthcare Cost Institute released the results of a similar analysis based on their national data set. So Healthcare Cost Institute has commercial claims data for employer-sponsored insurance for all 50 states, for Aetna, Cigna, and United Healthcare. They analyzed that data for 2012, 13, and 14 and generated measures similar to what the 5 states did in the work led by Henry and funded by the Robert Wood Johnson Foundation. And so the first 3 columns, 2012, 13, and 14, are the results based on the Healthcare Cost Index, or Healthcare Cost Institute's data. And what you see for inpatient and services is the Denver, Aurora, Lakewood region was 1% above average in inpatient spending, and this is a national average in 2012. That jumped to 7% in 2013. It jumped to 13% in 2014. The result we found in 2015, based on our own analysis, is that inpatient was 16% above that average based on the 5 states. Directionally, it's correct. From a magnitude perspective, it's also very close to that 2014 result that Healthcare Cost Institute found, a little bit higher, but that's in keeping with the trend from 2012 to 2014. In the outpatient category, Healthcare Cost Institute found outpatient spending 14% above average in Denver, Aurora, Lakewood in 2012. That jumped to 25% in 2013. It jumped to 37% in 2014. And again, that's relative to a 50-state average. In our work, we found 30% higher outpatient spending compared to the 5-state average. In the professional category, you see the results. According to Healthcare Cost Institute, 4% below in 2012, 5% below in 2013. That shrank to 2% in 2014. We found 5% above a 5-state average in 2015. So the takeaway here is that we were able to find a study that's similar based on a national data set, and they found results that were directionally similar as well as similar in magnitude to those that we found based on our analysis across 5 states. We saw a lot of variation too regionally, and I see some folks that are writing in with comments, questions, and whatnot. We're going to hold those until the end. I've just got a few more slides to get through here, and then we'll take questions and start responding to things that folks are sending in. The easiest way to submit a question is to click on the chat function and go ahead and type in your question, and please send those in, and we'll get to those here very shortly. We looked at variation across the state. It's interesting to understand how Colorado compares to other states with 17% higher spending. It's even more interesting in my mind to understand what's going on within Colorado. So the median PMPM, per member per month risk-adjusted spending, was $437 statewide. In this map, you see how the regions, based on Division of Insurance geographic rating regions, compare to that statewide median. The big winner appeared to be the Eastern region in Colorado with $591 per member per month. The lowest was down in Colorado Springs at $390. Only Fort Collins, Denver, and Colorado Springs came in below that statewide median. Pueblo, the East, Greeley, the West, and the Grand Junction regions all came in higher than that statewide median. We can break that into utilization and price components. So again, the first column of numbers is just that Division of Insurance rating area cost per member per month. You see the statewide median at $437, Fort Collins, Denver, and Colorado Springs below, the other regions all above. But what's interesting is when you break that into utilization and price components, sometimes utilization and price work in the same direction. Similar to the 4 of the states in the broader 5-state analysis, sometimes those work in opposite directions, similar to the Oregon story. So in the East and Greeley, 8% and 6% higher utilization respectively, and 21 and 17% higher prices contribute to them being the highest cost per member per month on a risk-adjusted basis in the state. Going down to the bottom, Colorado Springs, 8% below average utilization, 6% below average prices, contributes to them being, from a per member per month perspective, the lowest cost region in the state of Colorado. Pueblo and Boulder are like the Oregons in this example, where the impact of utilization and the impact of price relative to the statewide medians work in opposite directions. So both Pueblo and Boulder saw higher than median utilization. They both had lower than median prices, contributing to results that put their PMPMs just above that statewide median value. So again, it's not just prices that explain variation in healthcare costs across regions. Price and utilization are both important, and they sometimes work in opposite directions, which has important implications for policy. This map is similar to the overall total per member per month graphic 2 slides ago, but this focuses in on the outpatient category. So statewide, per member per month spending for outpatient services, these are services provided in a hospital-owned or hospital-affiliated setting, were $104 per member per month. Denver, Boulder, and Colorado Springs came in just below that number. Pueblo, the East, Greeley, Fort Collins, the West, and Grand Junction came in just above that number. It came in above that number to varying degrees. And similarly, we provide a breakdown in this next slide. You see the statewide median in the first column of 104, Boulder, Denver, and Colorado Springs below that, the other Division of Insurance rating area regions above. And here you see utilization and prices working in the same direction in some cases, and working in opposite directions for Pueblo, which saw 15% higher utilization, but 8% lower prices, contributing to their figure of 129. This graphic shows ordered pairs or results for the 126 practices that received practice level reports. So recall that the main goal, especially in the first phase of this project, was to provide very detailed information to adult and pediatric primary care practices to understand where they're doing a good job controlling costs for their patients and where maybe the costs for their patients are higher than average or higher than the median. We provided breakouts by inpatient, outpatient, professional, and prescription drug service categories. We provided a lot of detail within those categories. But what you see here are how practices around the state of Colorado compare on resource use and prices. So the vertical axis is the resource use index score. The horizontal axis is the price index use resource score. The statewide averages are right in the middle. You know, X marks the spot at 1-1. In the lower left-hand quadrant, those were roughly 32 practices that had lower than average prices and lower than average utilization, adding up to lower than average total costs. In the upper right-hand quadrant, you see roughly 21 practices. These are based on the 102 adult primary care practices. That's why I say that the percentages roughly align with numbers of practices. But you see roughly 21 practices with both higher prices and higher utilization contributing to their higher total cost of care. In the upper left and lower right-hand quadrants, practices saw a mixed bag with either lower prices and higher utilization in the upper left or higher prices and lower utilization in the lower right. But those practices could generally focus on one or the other. They could focus their efforts to reduce costs on one or the other, and these results tell them where they are. What's interesting, I think, about this is that there are practices in all four quadrants, and there doesn't appear to be any particular pattern, which to me emphasizes the point that you can't focus on prices alone, you can't focus on utilization alone if you hope to control total costs. Both matter. This graphic shows a little bit more detail around the specific categories of services. So up until now, we've been looking at total costs, total resource use, prices overall. The results, as I mentioned, the next level of drill down or the next level of granularity looks at these results by service category. And what we see here is that these are the 102 adult primary care practices. Why can't I get rid of this banner? Okay, well, it doesn't seem to want to. Anyway, sorry, and I just skipped ahead a slide. So if you look at these individual, these would be examples of results that an adult or pediatric primary care practice would see. So put yourself in the practice manager's seat at an adult primary care practice, and what these results at a very high level tell you as a practice manager is that in the professional category, for practices participating in Colorado, the average PMPM in the professional category was $160. Yours is $197. That suggests that's an area where you might look for opportunities to reduce utilization, find ways to reduce the cost of the services that you're providing to your patients, or perhaps both. And if you look at the breakdown of the bar chart, it's more a matter of resource use in the professional category, 26% above average, than it is prices, which are 2% below average in the professional category. It appears that this practice is utilizing professional services at a rate that's higher than average across the state. And again, that practice level report would provide drill down that would afford the practice manager an opportunity to see where opportunities might exist to reduce costs in that bucket. Outpatient and ED work at the two impacts of resource use and price index work in opposite directions. So if you're looking to control costs in the outpatient category, although this practice has below average outpatient costs, it would be a focus on resource use, 55% above average, that would make the most sense. ED is an opposite story. Again, this practice is doing well controlling ED costs for their patients at $15 compared to a statewide average of $18 per member per month. But again, that their ED result is driven more by prices, with average prices 41% above the average. It's driven more by that than it is 62% below average resource use. And a similar story can be told for inpatient, pharmacy, and overall. Within imaging, so a practice receiving these reports would get a lot more detail in the inpatient, outpatient, professional, et cetera categories. This is an example of a bit of extra detail that we provide in imaging. This practice is not different from the statewide average in terms of spending on CAT scans. They're below average on echo or ultra exams. They're below average on general imaging, which generally captures x-rays of various types. They're above the average on MRIs, and that might be something this practice might want to look at, although overall the practice at $33 per member per month on imaging is doing considerably better than the statewide average of 41. So who can use this information? Primary care providers, and they've been the focus of the initiative since the very beginning in 2013. We've now sent 3 rounds of very detailed practice level reports to adult and pediatric primary care practices around Colorado. The first time around, we sent reports to about 50 adult and pediatric primary care practices. The second round of this work, we sent reports to about 100 practices, and in this latest round, 126. And so we've been adding self-funded claims data to the Colorado APCD for plans not regulated under ERISA. Our ability to attribute patients to primary care practices has improved as the data quality has improved. One of the keys to this work is you have to be able to assign a patient to a specific primary care practice in order to be able to report results at the practice level. So we've seen the number of primary care practices with adequate numbers of attributed patients go up steadily in our subsequent rounds of this work. Policymakers. I think the geographic results are especially useful to folks considering policy changes that might help us control healthcare costs in the state. Until you understand how Colorado compares to other states and how regions within the state compare to statewide averages or statewide medians, you don't even know where to begin looking for options that might potentially be effective in reducing costs overall. In some areas, a focus on price is going to work, and that isn't going to work as well in other places. In some places, a focus on utilization is probably appropriate, but that's not universal across the map of Colorado. So just by highlighting variation in utilization, spending, and total costs across the state allows policymakers to identify specific pain points in specific regions and develop policies appropriately. Employers are increasingly getting squeezed, especially self-funded employers, by the cost of providing insurance on behalf of their employees. This information can be used by employers and other purchasers to understand where their employees are getting cost-effective, high-quality, low-cost, high-value care, and where they're not. And where there are problems or pain points, employers can lean on their third-party administrators to negotiate better deals or alter networks in ways that include high-value providers that provide quality services at relatively low prices. And consumers can use this information to get a sense of where they should think about shopping around for elective services, and this provides some information about how they might go about doing that. So the next steps, we continue to build out and increase the level of detail in the provider level reports, the provider practice level reports. Every time we send out another round of reports, we meet with primary care practices around the state to get their feedback. What's good, what isn't, what's missing, what would be helpful? Are there different ways to present this information that would make it more useful to you? Not surprisingly, something more current than 2015 data is something that's high on a lot of people's lists. And now that we're processing data each month here at the APCD, we'll be able to provide these reports on a much more timely basis. Another bit of feedback that we've had from the practices is add some quality information. It's great to understand cost. That's even more powerful with the price and utilization breakouts. It'd be more powerful still with nationally endorsed quality measures added to the mix. And so we're adding those quality measures to the practice level reports and incorporating other practice level feedback. By the end of this grant, we're in the final year of the grant, we are actually required to make some of this information available publicly at a high level. Civic has a statutory and regulatory mandate to generate comparative pricing and utilization information and make that available free through civic.org. We've made a lot of progress on that front. We have a lot more work to do. But one of the things that we intend to add to our public reporting is information based on some of this work that gives a sense of relative cost and prices across different practices. We'd like to get some more payers in here. We've got 14 plans represented in this analysis now. We're getting data from more plans than that. And so we want to add additional commercial payers to this analysis. We've also begun applying these measures to Medicare and Medicaid data in the Colorado APCD. And, you know, we heard from practices, especially pediatric practices, well, the commercial results are great, but some portion of our kids are covered by Medicaid. It would be really, really helpful to have a similar view into utilization, spending, and total costs for that Medicaid population as well. For adult practices, primary care practices, they often treat some number of Medicare patients. And so they want the commercial results alongside of Medicare. And again, from a public reporting perspective, we'd like to have a set of multi-payer results that we can share publicly through the website. And then finally, you know, we'd like to expand this to more practices as we're able to do so. We want to enhance our own public reporting. We want to modify the practice reports for employers and other purchasers of healthcare. We think there's a lot of work that could be done to aggregate some of this information and present it in a more user-friendly way to the policy community and policymakers in the legislature. And so we're always looking for new audiences and new ways of packaging this information in ways that are useful to them. To get geeky for a minute, the results of the Health Partners methodology are generated at the patient level. So with patient level results, there's almost no limit to the way that information can be rolled up and aggregated and reported to meet the needs of different audiences. So that concludes the sort of formal me talking all the time portion of the program. My contact information is there. You can reach out to civic.org. You can reach out to coapcd.org. You can reach out to me directly. I am happy to answer questions about this work and this initiative at any time. And I see we've got 3 items in the Q&A folder, and it looks like 15 or so in the chat box. So I'll stop talking all the time now and take some questions. You want me to do the Q&A? Okay. All right. I'm going to start with the Q&A, and then I'll get to the more and other things. I missed a couple of slides when you say cost. Is that total charges or payments after adjustments? Kind of in the middle. We don't do any. We receive charge information, but we generally don't include it in this kind of information, or we don't include it in these kinds of reports. We base this analysis on total allowed amounts, and that is the plan paid amount, the amount the health plan paid for the service. To that, we add patient responsibility. And patient responsibility is the sum of coinsurance, copay, and deductible. So we add what the plan paid to what the patient paid. We call that total allowed. And so that, according to the claim, is the actual amount paid for the services. And that's the basis for all of the calculations that underlie this methodology. Another question, on the scatter plot, is it possible to add geographic area notation? And I would say yes. The easiest way to do that is probably to color code the dots. And so we could color code the practice level dots by region and do that. Oregon, that's been part of this work since the beginning, actually did something similar. They graphed prices versus quality, and they graphed prices versus quality, found a similar scatter, no rhyme or reason to it, and they color-coded the dots by region, and there's no pattern to the color coding in the dots. They're all over the place regardless of color. The slide deck presentation and audio will be shared. We'll be sharing details of that at the end. Did utilization include all encounters, or was there any measure of potentially avoidable use? No measure of potentially avoidable use reflected here. Utilization and spending included all encounters as reported on claims. So if we don't have the encounters, if the encounters don't come in on a claim, we don't see it. So anything we can see in claims, you bet. Looking at Table 3, it seems to imply that the West Region PMPM is driven by exclusively higher prices at 33%. Is that a correct analysis? It is for the 2015 commercial claims data included in the study. Is it true for everyone in Colorado or everyone in Colorado with commercial insurance? We don't know that yet because we don't have insurance for everyone in the state of Colorado, or we don't have claims data for everyone commercially insured in the state, in part because of the Supreme Court decision 2 years ago that states could not compel self-funded plans regulated at the national level under ERISA to submit their claims data to state databases. What are the utilization drivers and which contribute the most to higher costs? Is it poorer patient health, unnecessary services or overuse of services, higher use of ER, et cetera? You kind of have to look at a holistic view that includes all of those service categories in order to really get a handle on that. I can say it is not generally poorer patient health because the dollar amounts are all risk adjusted. So the Johns Hopkins ACG or adjusted clinical groups is the risk adjustment method that we use along with the Health Partners Measure Set. I should mention the Health Partners Measure Set is nationally endorsed by the National Quality Forum, so it's NQF endorsed, and that NQF endorsement relies on use of the Johns Hopkins ACGs for purposes of risk adjustment. The types of services that are driving higher than average utilization or prices in a particular outpatient category, for example, is information that practices are provided in their very detailed practice level reports. We just didn't provide that level of detail in the presentation because our goal here was to give people an overview of the work that we've been doing in this area and not to get too deep in the weeds. But if folks want to set up subsequent meetings or discussions with Civic about this work, our findings have a desire to drill down to greater levels or more granular levels of detail in certain areas, we are absolutely happy to do that. That's it for the Q&A. I'm going to open up the questions in the chat and just run down these one at a time in no particular order. How much did the practice level results align with the region level results? Things are moving and disappearing and whatnot. So we will post slides and the recording within the week and notify you when it's available. Which platform do you use to aggregate the data? Civic contracts with an outside data manager. We started out with Treo Solutions. They were purchased by 3M, and now we work with Human Services Research Institute out of Cambridge, Mass, and National Opinion Research Center out of the University of Chicago. They intake the data on our behalf. We have very extensive business rules in place that govern processing of the data. That data gets processed and stored in an APCD data warehouse or a data enclave that's maintained by the National Opinion Research Center in Chicago. And the more granular technical details of that would have to come from one of our more granular technical people. So it's not a particular platform, but we have outside data managers that undertake this rather Herculean task on our behalf. Next, how much did the practice level results align with the region level results? Pretty well to some degree. I think generally practices in the mountains and western regions, we saw higher total cost of care driven by both utilization and prices relative to the front range. So there are always stellar performers, or there's always performance variation within a region as well as across regions. But for the most part, those regional level results align pretty well with what we saw for individual practices within those regions. Were there practices that went against the grain of their region, either on utilization or price or both? Yes, and there's a lot of variation both within the service categories, inpatient, outpatient, professional, pharmacy, as well as across those service categories. Similar to the work that we did for the Commission on Affordable Health Care here in Colorado, when we looked at the cost of a dozen or so services across different regions of the state. There was no region with all high-cost services and one region with all low-cost services. Things were more expensive in one region and cheaper in that same region than they were in other regions. I think one of the most vexing things about trying to control healthcare costs is that there's no rhyme or reason to it. And it's very hard to make general statements about what is, what's driving the results. Does Figure 5 control for the different acuity levels of patients seen by each practice? Yes, all of the results of this analysis are risk adjusted using the Johns Hopkins ACG system, a very commonly used risk adjustment tool and part of the NQF endorsement of the Health Partners measure set. The next question, what is patient satisfaction in these same areas? Who paid less, paid more? We don't have information on quality or patient satisfaction built into these measures. As I mentioned, we plan to include that kind of information in our public reporting and in the practice level reports going forward. So it's a little hard to, again, a shortcoming of the analysis really is it doesn't speak to value from a cost and quality perspective. This speaks entirely to costs. It, for the first time, I think, provides good granular detail around whether it's utilization, prices, or both driving variation in costs. But, in my mind, I agree with the question, the premise of the question. We're a long way from value because we're not explicitly thinking about patient satisfaction or quality in what we're reporting here. Table 3 seems to contradict the earlier graphic that said prices have a slightly bigger impact than utilization. Table 3 makes it look like price differences are more important. Let me pop back for just a second. In percentage terms, that's a good question. I'm going to need to think about that one a little more. I don't have a good response to that off the top of my head. Overall, uh-oh, what did I do? How do I come back? Oh, I think we just open that back up again. Sorry for the editorial comments, folks, but I've lost the chat. Table 3. Let me pull up table 3 here. Okay. Table 3 seems to contradict the earlier graphic that said prices had a slightly bigger impact than utilization. The earlier graphic speaks to Colorado compared to the other states, or Colorado compared to the 5-state results. This graphic speaks to regions of Colorado compared to Colorado as a whole. And so that's going to be a little different. When we compare Colorado to the average across 5 states, that's one thing. When we compare regions within Colorado to the Colorado median, that's another matter. And the resource use or utilization and price drivers in those two contexts are different. Does the study have the ability to reflect how price and utilization can be related to overall health of the local population? To some extent, the health of the local population is taken into account through risk adjustment. Risk scores are generated at the patient level. They reflect the underlying health status of each patient. We aggregate those by region. So to some extent, we're capturing that. That would be information that we could add to reporting here. So you could see not only, I'm looking at the table 3 again, not only did the East have 591 cost per member per month, we could add the average risk score for patients attributed to practices in the East. And I think you'd see the average risk score for those patients is higher than the statewide average. And even though the impact of that higher than average risk score is baked into the higher than average spending, it's an additional piece of information that helps to inform that a little bit. If utilization is up because the local community has higher risk levels, again, that's adjusted for in these dollar amounts. It's adjusted for in the resource use calculations. It's implicitly adjusted for in the price calculations. But yeah, I think that's another piece of information that we could include in the outputs to help people understand that issue a little better. Does this include supplemental plans for Medicare beneficiaries? No Medicare at all reflected in these results. No Medicaid at all reflected in these results either, but we are applying the measures to Medicare and Medicaid. Supplemental plans would generally be removed. So if somebody with commercial insurance has a supplemental vision, dental care, that is not reflected here. The 14 health insurers that were included in the analysis reflect full coverage plans with per member per month spending levels that reflect full coverage. So we take out vision, dental, hearing, those kinds of partial coverage plans, behavioral health only, student plans, which tend to have very, very low PMPMs. We remove those from the analysis at the initial quality assurance phase, or the initial QA phase, and include only those plans that have PMPMs suggesting that they provide full coverage. And pharmacy is included in this. So Medicaid is not included in this study. Medicaid is included in the APCD, I think. Yes, Medicaid is included in the APCD. Medicare Advantage and Medicare Fee-for-Service are as well, and we will be applying these measures to Medicaid, Medicare Advantage, and Medicare Fee-for-Service. Well, we're actually working on that currently, and we'll be releasing results related to those analyses going forward. TRICARE data is not included in the Colorado APCD. Absolutely true. Thank you, Stephanie. So Colorado APCD has fully insured commercial plans. We are collecting data from self-funded plans that are not regulated under ERISA because of the Supreme Court decision 2 years ago. We are collecting Medicare Advantage claims from the commercial payers who administer those plans in Colorado. We get Medicaid data from the Department of Healthcare Policy and Financing. We receive Medicare Fee-for-Service under a state research data use agreement from the Centers for Medicare and Medicaid Services. We do not get federal employee health benefits, veterans, TRICARE, Indian Health Service. Those are federal health benefits programs that the federal government is not currently sharing claims data for with entities like state APCDs. Outpatient includes specialty. What is professional? So inpatient claims are multiple day stays in a hospital. That's how those are identified. Outpatient services can include services provided by doctors and non-physician providers. The key to an outpatient service is it's provided in a facility that's either attached to or owned by a hospital or an ambulatory surgery center. So if there's a facility code on the claim and it doesn't involve an overnight stay in a hospital, it's a single date of service, that falls into the outpatient category. Professional services include all services provided in a doctor's office setting, and those types of claims are submitted on a different form than claims for inpatient and outpatient services that are associated with a facility. So outpatient includes specialty, so does professional. The difference is, was it provided in a provider office setting, or was it provided in a facility owned, affiliated with a hospital or an ambulatory surgery center? TRICARE does not count in the commercial payer bucket. Yes, thank you, Steph. The study reflects commercial payers only. This is this Affordable Care Act data only? And the Colorado APCD has no connection to the Affordable Care Act. We were not created by or as a result of the Affordable Care Act, neither was Civic. Back in 2007, the 208 Commission, Blue Ribbon Commission on Healthcare Reform, met in the state of Colorado. They issued a number of recommendations specific to healthcare reform in Colorado. One was to create an entity that would coordinate healthcare reform efforts around the state, and Civic began within the Department of Healthcare Policy and Financing and spun off as an independent nonprofit, but based on that recommendation of the Colorado Blue Ribbon Commission. The other recommendation that's relevant here is the Commission recommended creation of an all-payer claims database for the state of Colorado. Responsibility for implementing the APCD was given to the Department of Healthcare Policy and Financing. HCPF appointed Civic administrator of the APCD, and again, no connection to Affordable Care Act. We do have data from health plans sold on the exchange, the Health Benefits Exchange. And of course, the existence of health benefit exchanges is an effect of the Affordable Care Act, and that data is reflected in this analysis to the extent that the health plans administering, the health insurers administering those plans made the cut in the initial data quality assessment. But again, this is not anything that's specific to the Affordable Care Act. That's Stephanie, and I see there's one more new one down here at the bottom and a couple of new QAs. Does the data include information from payers where value-based ACO contracts are in place for the population as well? My hunch is yes, but we don't have information on value-based payments or alternative payment models in the APCD at this time. So what we have are claims, services paid for under the traditional fee-for-service arrangement. And so we see the dollars that the health insurers pay and the dollars that the patients are supposed to pay for the services that they receive. We are working to add data on value-based payments, including ACO-type payments, to the Colorado APCD going forward. And we will have a better window into that world when we're successful at doing that. But currently, we don't see any value-based payments. So if patients' care is paid for under a global budget or a partial budget or an episode or bundled payment arrangement or quality incentive payment or cost incentive payments, we don't see that explicitly in the APCD now, but we're working to correct that. There are two more in the Q&A bucket. Great data. Is Civic willing to draw any conclusions or publish any recommendations based on this data? So the 5-state results appear in a paper recently published by the Network for Regional Healthcare Improvement. We can send links to that publication after the webinar. We also created internally here at Civic a white paper to accompany release of the 5-state Network for Regional Healthcare Improvement report. That is also available, and we'll share the link. It's available on the civic.org website. We'll share the link with people on the call. So we have drawn some conclusions and published any recommendations. And I would say that we're still at a fairly early stage of this work. We are still at the starting to stand up, getting beyond crawling stage of making results based on this work available publicly, and we plan to do a lot more of that in the next year or so. You have mentioned twice that you have self-funded data that is not subject to ERISA under a court case. This is confusing. Could you please explain the limitation you have on the self-funded data you're collecting? Yep, that's confusing to a lot of people, and it was to me too. So there are two types of commercial insurance: fully insured, where the insurance company is at risk, financial risk, for care provided to people covered under their policies. So Aetna issues insurance policies directly to people on behalf of employers, et cetera. And with a fully insured commercial plan, Aetna is at risk if the person gets in an accident or develops an illness that requires a lot of high-cost treatment. For quite some time now, I wouldn't even venture a guess as to how many years, the commercial marketplace has been moving in the direction of what are called self-funded plans. So a company like Aetna administers a health plan on behalf of an employer, but the employer is the one at financial risk for their employees or their dependents having accidents or developing severe illness. And as I understand it, self-funded plans tend to be a little bit more expensive for employers and their employees. Self-funded plans have been presented as an alternative that can help to lower costs. The cost of providing insurance by employers on behalf of their employees. In Colorado, 40 to 45% of the commercial market is fully funded or fully insured. 55 to 60% is self-funded. Within that self-funded marketplace, some plans fall under ERISA, the Employee Retirement Income Security Act, at the federal level, and some do not. So typically, national or multinational companies that have a presence in Colorado, their self-funded plans would be regulated under ERISA. State and local government, school districts, public utilities, and others located solely within Colorado, their self-funded plans are typically not regulated under ERISA. No, because the organizations that administer these plans are not regulated in Colorado, we don't have good hard numbers, but about a third of the self-funded plans are regulated under ERISA, about 2/3 are not. Under Colorado APCD statute, we require submission of claims data for the non-ERISA self-funded plans, but a Supreme Court decision 2 years ago essentially forbids states from requiring submission of claims data from the ERISA self-funded plans. So we can't require submission of that ERISA self-funded data. We do require submission of the non-ERISA self-funded data, and hopefully that helps. And I can provide additional detail if you send me an email directly, but that's the sort of long-winded answer to a confusing issue, or an issue that baffles a lot of people. The other thing too is that, you know, Civic was created, to a question a minute ago, Civic was created to be a neutral convener. We're not an advocacy organization, we're an independent nonprofit. We administer the Colorado APCD on behalf of the state of Colorado. That makes us a little unique in the APCD world. We're also not just the APCD. We are active in the areas of payment reform, doing research, generating information, and doing convenings to bring stakeholders interested in payment reform and delivery system redesign topics together to discuss pain points and potential solutions. But we don't make policy recommendations. We do a lot of analysis of the APCD data, and we make it publicly available through civic.org. That's part of our statutory mandate, or our requirements under the APCD law here in Colorado. We sometimes are asked by legislators and others to do analysis based on the APCD that speaks to a specific specific issues, and we make that analysis without judgment available to the people who request it. But we do not take specific positions on legislative matters or particular policy issues. We exist primarily to leverage the power of the APCD, which was created by the state government for the benefit of all Colorado residents, to help inform those issues when they arise and when questions come our way. So I don't see any more chat box questions or Q&A. If folks have anything else that's on their mind, please send something into Q&A or the chat box. In the meantime, thank you all for joining. I'm seeing about 50 participants here, according to the tote board. Thank you for joining us today. Thank you for listening. Please feel free to reach out if you have additional questions. Civic.org, coapcd.org. My email is up there on the slide on the screen. Thank you so much for coming. Thank you so much for listening. And please don't hesitate to reach out if you have additional questions.